connecting to recording. Okay, the session's in progress. All right, Saul Cobbing, I'm so happy to welcome you to the WCPT IPT-HOPE quarterly online education session. I'm Jackie Drew, and I'm the president of the new subgroup for HIV/AIDS, hospice, and oncology, and palliative care. So Saul is going to be joining us today and talking about a home-based rehabilitation program in South Africa, and I will shut my information down so you can talk, and you can let people know if you want to have them ask questions during the session or if you'd rather have them asking afterwards. So here you go, Saul.
Sure, thanks, Jackie.
Welcome.
Okay, hello everyone. Welcome. Thanks for the welcome, Jackie. The introduction. So you should hopefully all be able to see the title of my talk today on the screen. So I'm talking about a home-based rehabilitation intervention for people living with HIV in a resource-poor community in KwaZulu-Natal province, South Africa. And that's indeed where I'm sitting right now. It's winter in South Africa, and if you look at the picture on the right of the screen, that shows how we have very nice winters in Durban. So I'm in Durban, which is the biggest city in KwaZulu-Natal. And yeah, you can see it there. If you look closely, you'll see their surfers out on the waves there. I'll put my details here as well. I'm a lecturer in the Department of Physiotherapy at the University of KwaZulu-Natal. My email address is there if anyone wants to get hold of me. Following Darren Brown's lead, I watched his seminar. I've put my Twitter handle as well as the hashtag #RehabHIV on Twitter. That's something I've started getting into quite recently. And then also, just at the bottom of the page, you'll see a nice quote from Stephanie Nixon, who's someone who I know and has inspired me to do some of the work I've done now. And I like this quote. It says, "Whereas medicine adds years to life, it is rehabilitation that aims to add life to years." So I think probably quite a lot of you listening are physiotherapists or other rehabilitation professionals or people interested in rehabilitation. So I think that'll strike a chord with all of you. If any of you want to ask a question, Jackie and I had a little practice session yesterday, so I believe you can type in a question there, and feel free to do so during the lecture. I'm happy to answer them as we go along, but also at the end, there'll be time to answer some of those questions. I'm not going to talk for the full hour. I don't think so. So there should be more than enough time at the end to look at some questions. So I'm just going to go through the PowerPoint I have here, and we'll take it from there. So, okay, Jackie? Okay, so I'm going to continue here. Just some facts about kind of global HIV prevalence, because I know this group has people who are interested in all sorts of things, oncology and palliative care. Globally, if you look at that map, you'll see quite where it's darkest is where we have the highest prevalence in the world, very much in sub-Saharan Africa, and particularly in southern Africa, where I live. So the facts I've got, many of the facts are from UNAIDS. At the moment we're standing at roughly 37 million people globally living with HIV. Approximately 70% of the global HIV population live in sub-Saharan Africa, and women are disproportionately affected, with about 58% of those people being female. New infections this is something that has got better, certainly in South Africa, but 1.8 million people still annually being infected with HIV, very, very far away from the 2020 target of 500,000 annual infections. A similar story with annual deaths from HIV/AIDS. We're looking at under 1 million people now dying annually, 940,000 in 2017, but that's still, way, way above what we'd hoped, albeit being a 50% decline from 2005. At the height of the infection, we were looking at about 300,000 people dying annually, and many of those in sub-Saharan Africa. Sadly, we have 1.8 million children living with HIV, and again, most of those being in sub-Saharan Africa, despite great improvements in mother-to-child transmission. And then my country, South Africa, I think you should see a little red arrow pointing to where that's specifically where we live on the east coast of South Africa in KwaZulu-Natal. 2017 statistics showing almost 8 million people living in South Africa, which is close to 20% of our population, which is fairly sobering statistics, almost 1 in 5 people being HIV positive. Still accounting for approximately 14% of all deaths in South Africa annually. At the moment, about 110,000 deaths per annum can be attributed to HIV, which is down from over 300,000. And, that's when I started working in the area of HIV as a physiotherapist working in a palliative care facility in Durban in 2007, before treatment was really freely available. It wasn't uncommon for me to come into work and, 5 or more patients had died that night or the night before. So, things are getting better, but it's still, really unacceptable, of course, that 110,000 people in South Africa alone are dying from HIV. And my province, KwaZulu-Natal, which is the second largest province in terms of population, also really can be seen as the epicenter of the global epidemic, with the highest prevalence of any of the 9 provinces in South Africa. Current prevalence of about 26% of people in KZN province living with HIV. And a last statistic, there are many, many more, but try and keep it fairly limited. Life expectancy, and this is in South Africa, is now up at about 64, which has gone up a lot in the last 15 years. In 2005, average life expectancy was 52, and now it's 64, with 61 for males and 67 for females. But if you look at developed countries, I think Japan has a life expectancy around 90, and many of the Western European and other countries in the mid to late 80s. So, you're still seeing many, many lives or years of life lost, and certainly many more years of disability experienced by people in this region, a lot of which is attributable to HIV and the opportunistic infections associated with HIV. So to put it into a bit of context, I think everyone here listening will probably know about the 90-90-90 targets. For those of you who don't, the goal across the world is to make sure that 90% of people are tested and aware of their status. Of those, that 90% of people are on antiretroviral treatment, And then of those, that 90% of those people have viral suppression. And what we know now, if you're virally suppressed, it's clinically now thought to be impossible to then transmit the virus to a partner. In South Africa, again, sadly, we're nowhere really near those targets. We have, apparently, and I'm not completely sure of this, or I'm not sure if I believe it, but apparently 90% of South Africans are aware of their status. But only 68% of those are on treatment, and only 78% of those are virally suppressed. So what it means in practice that 47% of people in South Africa living with HIV are virally suppressed, so less than half, in other words, which obviously has great implications for those individuals, but also for trying to stop new infections. And all this data comes from Avert, which is a very nice website. You guys can check the link below there. And, as I said to you guys, I'm a lecturer in physiotherapy at UKZN, and I try to have these discussions with our students because in our clinical placements, at least half of the patients we see are HIV positive. And it's important they know not only, the medical facts around HIV, but a lot of the socio-economic factors, political factors related to HIV. And I have quite a nice long session, and if I had more time and could be more interactive with you guys, it would be wonderful to talk about this in more detail. But we talk about, we spend a couple of hours talking about the context and why it is that South Africa has such a high rate of HIV infection and a low rate of actually getting people on treatment and getting them virally suppressed. And these are just some of the things we discuss, and I'm sure many of you will have other ideas. And this may relate to the countries where you live. Stigma is a major problem, and I know this is a worldwide problem. Along with 90-90-90, there's a target of zero stigma. I don't know if that is possible with any disease, be it HIV or cancer, but it really remains a major problem in South Africa, and there's research backing that up. And indeed, my own research, which I'll talk about later, this became apparent as a really severe problem. Education remains a problem, getting the right message to people. Often the messages are based with a certain agenda and, unrealistic. Let's, for example, talking about abstain, be faithful, condomize, these kinds of messages, while useful, aren't always indicative of the kind of full spectrum of experiences and the context in which many South Africans live. But clearly, better education, more clear messages would help in this regard. Culture and religion are always difficult things to talk about. We are a multicultural society in South Africa. We have, 11 languages, many different religions and ethnic backgrounds. And these are things we talk about, and I can't go into in great detail here, but these have an impact on the work that we do, on people's perceptions of HIV. There are all sorts of myths and mystery around the virus, and culture and religion are things that are sometimes seen to be static and unchanging, but we know they can adapt, and culture and religion are always evolving. And that actually takes me to the next bullet point around circumcision. So in the province I live, which is KwaZulu-Natal, the Zulu reflects the major ethnic group, in our province, which are isiZulu-speaking people, and traditionally Zulu men were not circumcised, and we know that circumcision is one thing that can help prevent the spread of HIV, medical male circumcision. And it's, you know, great kind of credit, I suppose, to the king of the Zulu a few years ago, you know, looking at information from research and advocacy efforts, spoke to Zulu men and said, this is something that's now seen to be acceptable. You know, as a traditional leader, he effectively sanctioned Zulu men being circumcised. And, you know, a lot of men from research are saying they still don't want to circumcise, it's not in their culture, but a lot of people are taking up circumcision, and this is helping to slow down the new infections in our province. Medication is obviously something that's been a great thing in South Africa. You know, when I first started working in this area as a physiotherapist, people didn't have access to ARVs, and if they did get access, they had to be really, really ill. They had to have a CD4 count of below 200 to get medication. Now we have probably one of the best, you know, ARV responses in the world with test and treat. So as soon as someone is tested positive, they can immediately go on to medication. The medication has improved, but still in South Africa, there's still only 3 lines of medication. So you wouldn't see perhaps the range of medication, you know, given specific to who you are that you may have in some other countries, and certainly that private patients would have in South Africa. And in South Africa, the state is responsible for close to 90% of all people. So most people are still getting their medication on the state. Type of HIV, this is, you know, very sort of medical, and it's very in-depth. I won't go into any great detail, but, you know, the subtype of the virus that people in South Africa have is different to the type of the virus that people in Western Europe and America have. And the research is very conflicting here, but, you know, it's not clear if the medication that people living with HIV in South Africa have will be as effective as it is in the West, where the drugs were developed based on the subtype of the virus over there. Also, there's some debate whether the virus type in Southern Africa or Sub-Saharan Africa is more easily transmitted, and there's some debate on that. But I'm not going to be talking about that, but just to be aware that it's a complex mix of medical factors, but also the socioeconomic factors I've talked about, sociocultural factors. Poverty is a big one. You know, we have extreme poverty in South Africa, and particularly the kind of area where I did or am doing my research. But poverty alone does not explain it. You know, there's some countries with a lot of poverty, but not very high rates of HIV infection or high prevalence of the virus. One thing that has been shown to have a very, very strong correlation with HIV infection rates is inequality. And South Africa, sadly, along with having the highest prevalence of HIV in the world, also has the dubious distinction of having the highest inequality of any country in the world according to Gini coefficients. And where you see high inequality, very, very wealthy people, and almost side by side living or a few kilometers away from extreme poverty where people don't have enough money to feed themselves, you see all sorts of problems related to social problems, also to, for example, the phenomenon of sugar daddies, for example, which is something that's really driving the epidemic amongst young women. So I said earlier, transmission rates are going down, but the one area where they're not going down is in women of the age 18 to 30. And there's issues around intergenerational sex that's driving the epidemic in that demographic. But I think across the world, even in wealthy countries, where HIV rates are on the rise, is often where there's areas of great inequality. So I just wanted to give you the context in which I work and what kind of inspired me to get into this area of rehabilitation for HIV. So to talk a little bit around HIV and disability, and a lot of this work is done by Professor Jill Hannes-Hancock, who also works in this province. She was my PhD supervisor, and she talks of the cyclical relationship between HIV and disability. So there's a graphic of Jill's that kind of illustrates it quite nicely. I think people are quite comfortable with the idea that having HIV puts you at a risk of various disabilities, physical and cognitive disability. But what's perhaps less well understood is that people who are people who are living with disability are actually at a greater risk of becoming infected with HIV. And that's often contrary to what people expect. There's this idea that disabled people are somehow asexual or don't have the same risk. And for all the risk factors of contracting HIV, things around education and abuse and all sorts of factors, people with disability are at a high risk of becoming infected with HIV. So that cyclical relationship exists. This is the front page of a paper by Jill, as well as Helen Maezwa, who is my other PhD supervisor. And both of them are very prolific in writing around HIV and rehabilitation and disability, if you want to look up some of their work. They wrote this paper together with Bradley Carpenter. And this paper is looking at, over 1,000 adults in my province who are on antiretroviral drugs and looking at levels of disability. And, conservatively, we're looking at 1 in 3 people in this cohort who are living with some kind of disability affecting their participation, limiting their ability to do day-to-day activities. So equally, Helen, who's the second name author there, is the lead author on a paper in Gauteng province, which is the province where Johannesburg and Pretoria are, and similar kind of number of people. And she actually looking at 1,000 adults, and there you had a percentage of over, I think, around 52% of people with activity limitations and participation restrictions, suggesting some level of disability. So really, really high rates of disability if you're comparing it to a kind of global average of disability of around 10%. And what we do know, and I know Darren spoke about this in his presentation, and this is becoming quite well understood, this idea of episodic disability put forward by Kelly O'Brien and her colleagues, how, living with HIV and living with disability, it's not a static phenomenon where, every day is similar. You're literally having sort of good days and bad days depending on a whole variety of factors. And I'm not going to go into this at length, but it really makes delivering rehabilitation interventions and understanding people who live with HIV and disability both particularly difficult, but also particularly crucial to understand and make sure we are offering novel alternative rehabilitation solutions for these people. It becomes complicated when you look at all the comorbidities associated with HIV. And again, I could spend hours talking about this, but the big one in South Africa is tuberculosis. You know, I understand in Europe and America, there are very low rates of TB. In South Africa, the co-infection rate between TB and HIV is scary. You know, it's often a given in hospital when you're treating a patient who's got HIV that they'll also have TB. And it's often drug-resistant forms of tuberculosis affecting the whole body. You know, everyone knows how sort of TB can affect the chest, but affects the whole body, musculoskeletal system, the neurological system, causing all kinds of problems. So getting an understanding of the comorbidities of HIV, particularly in the region where you live, is crucial to start becoming, you know, getting the rehabilitation going. Is there a question there, or I just heard some background conversation, but if anyone wants to send a question, you know, feel free to type one in. I think there's a Q&A section there, but otherwise at the end there'll be space for questions. So mental health is a big thing, and I'll talk a little bit about this when I talk about my own research, that, you know, clearly we have to look at disability beyond the physical. I've just had a look at my watch, I'm rambling on a bit, so we'll move ahead. Rehab helps. I'm not going to go into this. You guys all know how crucial rehabilitation can be, but in a nutshell, rehabilitation, all the bodily systems that HIV affects and the comorbidities of HIV affect, rehabilitation can help, and that's including mental health issues. So the quick background to my study, you know, where I worked, it was clear there's a lack of access. People who have HIV were very lucky if they even could get to the local hospital, which was in a rural part of KwaZulu-Natal. And if they got there, there was one physiotherapist, no occupational therapist, and at most they'd have one session of rehab and probably never come back. There are various barriers to people getting to the hospital or returning for rehab, and this was my master's work, but it looked around barriers around cost, obviously, transport, getting there, and then attitudes of healthcare professionals when they did actually get to the hospital, but many, many other barriers. There are very, very few rehabilitation professionals in South Africa, and I know it's even worse. We are a relatively wealthy country in Africa, and it's worse across the rest of Africa, but just one stat I can give you is, in terms of physiotherapists, we have 2 physiotherapists per 10,000 population, whereas, you know, in parts of Europe and America, it might be more like 20 physiotherapists. So, you know, we have a 10% of the professionals, but a huge burden of disease. So there's a real mismatch there. And this got me thinking that we really needed alternative rehabilitation solutions. My colleague, Farusha Chetty, who works in the same department with me, has done amazing work, and she put together a theoretical model of care for her PhD, and it's best summed up by this wonderful graphic that she put together. But essentially, what came out of this is that it's very important that the person living with HIV experiencing disability is at the center of any care intervention, and ideally in their home. So you'll have access to these slides after the presentation, and I urge you to look at her work. There's a reference at the end, but this was sort of going currently with my own PhD, and it certainly focused the intervention that I came up with at looking at people's homes. So I did a scoping review methodology looking at what research there had been, and this was around 2015, and I could only find 5 studies of any description that had actually looked at home-based rehabilitation interventions for people living with HIV. And 2 of them were actually just case studies. The other 4 were randomized controlled trials. And they helped me design my own intervention, which I'll talk about now. What I saw as both being necessary because there are very few physiotherapists working in this area, but also in the sense that community healthcare workers, so I'm talking about lay home-based carers who do a lot of amazing work in these rural communities, I knew they would need to be central to any intervention I designed. So I had to do a bit of a crash course with these amazing women who helped me, 4 of them, and essentially train them up on basic rehabilitation interventions that would form part of my PhD study. So briefly, and these different steps of my PhD are all written up in different papers, the references are at the end. But briefly, the home-based rehabilitation program that I designed was informed by the scoping review that I've just discussed. It was a single-blind randomized controlled trial, so of course the participants couldn't be blinded because they knew they were getting rehabilitation. The control group received the standard of care, which is very little, as we know, but ethically I felt it was certainly important to give them information on living a healthy lifestyle and exercise, which I did. There were 76 participants, all adult people living HIV, so over the age of 18. I think the oldest participant was 65 at the time, split into 2 groups of 38. And the intervention was 16 weeks, so again, this was informed by the literature, not just in HIV, but in other chronic disease populations. So looking at 4 months with people being seen once a day by myself and the home-based carers. And it was challenging. I think I've got some pictures here, yes, of the environment we worked in. And this doesn't quite show the terrain. This is a semi-rural area, very rugged. So walking up and down, often you have to park your car and then walk kilometers into the valleys. And we live in a very hot climate. So seeing even 4 or 5 people a day was a lot. That's an example of the kind of home that people are living in. So very, very poor people, but very resilient people. And it really couldn't have been possible for me doing this without my 4 research assistants who knew the area, spoke the language. I mean, I speak what I call Physio Zulu, so I can tell people to stand up and lift their arm and do various things, but my conversational Zulu could be much better. So I really, really relied on my research assistants. What we found, so we did various measures before and after, but broadly what we found with the intervention group, that we saw improvements in levels of function, quality of life, the specific HIV quality of life tool we used, as well as aerobic capacity when we used the 6-minute walk test before and after the intervention. And that's not really surprising, you know, having had 16 weeks of rehabilitation. And I should say here, the rehabilitation we did was quite novel in the sense we used a needs-based intervention. So it wasn't one size fits all. So a lot of home-based rehab interventions or exercise interventions are, you know, everyone gets the same thing. And that's really what RCTs kind of demand. But I felt ours needed to be a real-world intervention. So we looked at tailoring it to the person. So if someone had had a stroke and couldn't walk, we spent the hour with them doing gait retraining and doing neurological techniques to help them. Where someone else who was maybe had other kinds of issues, we'd get them out of their house and walking around the community and doing strength exercises with TheraBand, and you know, we try to focus on really practical, low-cost solutions. But you know, they improved pretty much across the participants. So I've talked about this task shifting model. So essentially training community healthcare workers, and we'll hear their voice a little bit later. But I often felt, even though I was the PhD student, I was learning a lot more from them because of their local knowledge. And what was very interesting, and again, shouldn't really be surprising, but it was initially, was when we started looking in the data, seeing the improvement in the control group across all these measures, not to the same level as the intervention group. But what this showed, I think, you know, other than maybe an improvement you'd see over time, was more that just giving exercise advice and health tips in someone's own language really seemed to get them. And when we did interviews afterwards, we found it actually got people up and about and realizing there are things they can do, and they improved across all these measures. And that's quite informative, because even if we can't get rehabilitation professionals in all the hospitals and clinics and going out to people's homes, at the very least we need to be giving people advice and information at the point of testing. I've just got a question here, it's my first question. Okay, so how many times did you administer the exercise in a week? That's a lovely question, John, thank you. So we went to people's homes once a week personally, so hands-on kind of home-based rehab, but we encouraged people to, so we gave them a home program that we encouraged them to be doing 3-4 times a week, and people kept diaries, and it was quite a range of the kind of people sticking to doing it on their own. We had variable success there, but some people really did do it almost daily, and it was great. People were starting to do exercise sessions with their neighbors and with other people they knew around. So thanks for that question. Just moving on. So last couple of slides, I thought we'd have the voices of the community. CHWs stand for community healthcare workers. These are the 4 women who were my assistants, but really my guides in the community. And here are 4 of their quotes. And this is in a paper that we've written up, and you can see a lot more of their voice in the paper. And this is actually the title of the paper, but it's such a lovely quote. So knowing I can be helpful makes me feel good inside. It makes me feel essential. And it's wonderful that these women were upskilled and learned themselves and realized the impact they can have beyond basic home care duties. This is another quote. I now also help other community care workers with advice related to rehabilitation. So there are a lot of unsung heroes in South Africa, and I'm sure across Africa and the world, these sort of lay community workers who often pay very poor wages or often volunteer, and they really felt empowered by helping the others who weren't trained by myself. This was quite a nice quote. One of the women said, I learned that being in a wheelchair doesn't make you disabled forever. So, you know, some of the patients who you know, let's say didn't have a spinal cord injury, but were in a wheelchair either from tuberculosis, for example, or from just disuse, you know, saying that we can get people out of the wheelchairs and get them up and about, and even those people who are permanently in wheelchairs really improve what they're able to do. And it wasn't all great and easy. It was actually quite tough walking around, hot climate. And this happened, you know, I was with this woman when it happened. Another challenge was when 5 dogs attacked me. So this woman was attacked by dogs, and I had to wade in, kicking the dogs and screaming, and luckily the dogs ran off. But she had to get, you know, I had to take her to the doctor. Luckily she wasn't too badly hurt, but she did get a superficial bite, so she had to get on treatment for rabies, but thankfully she's fine. But it just shows the real challenges of doing this kind of work. You know, there's a lot of talk about getting out there and doing community-based rehab, home-based rehab, but in resource-poor rural environments, it's very, very challenging, and transport's an issue, cost is an issue, and as I said, to even see 3 or 4 patients a day is good going. We've had a paper written a year after the intervention, hearing the participants' voices. How were they doing a year later? And this is some of their quotes. So this was one of the participants. Before joining the program, I had become prone to constant pains physically. Now I can walk. Another quote, you know, and this is people speaking in Zulu, so sometimes it's quite hard to translate it verbatim in English, but this is a lovely quote. You know, that she's talking about the exercise, it really does untangle your stress. It untangles your body. So she literally felt freer and untangled and ready to do more. This one, the participant said, before I considered myself as a sick person, after the program, I started feeling free. And a final quote, I encourage most of the people to exercise, as this is not only for me, but for others as well. And this started happening almost organically. The people, particularly after the program had ended, they carried on, and when neighbors asked them, what are you doing? They talked about how exercise can help, and they started forming, you know, teaching their kids and their family and their neighbors, and starting groups in the community. So they really felt a sense of empowerment, and this was a wonderful outcome, sort of unintended consequence of the research. So what next? I want to leave some time for questions. So, you know, this, I'm putting it out there. It's also for you guys to contribute. A few points that just got me thinking. And that slide with the hand is, I do a lecture on advocacy with my students, because I often think research alone really gets us nowhere, but unless you're an advocate, you're not going to make a difference. So, you know, what I'm doing now in my postdoc work, and this is a conversation for another day, but is really I'm really looking at trying to influence national policy. So getting the rehab message out there, not just myself, by the way, with my supervisors, with my colleagues across the country, with amazing people doing wonderful work. We're a long way off, I'll be honest with you. It's very, very hard, as I think most of you guys know, to influence policy, but we're working on it. And that's linked very much to implementation. So, you know, we don't want our research to be something that starts and ends, you know, with a degree or with various papers, but implementing these novel interventions that people are trialing across Africa and the world, and making sure people are doing it in their practice. I really feel quite strongly about stopping this thing of HIV exceptionalism. I was a bit guilty of this in my early years working in this field, but, you know, for various reasons, including stigma, we must stop thinking of seeing HIV as completely different and treating people separately. You know, South Africa had clinics where you just went to get your HIV drugs, and, you know, this is all sorts of problems, and it's changing now, but we need to look, and my postdoc work is looking at how HIV relates to all sorts of other chronic illnesses and disability. And indeed, the interventions we bring in must not only be for people with HIV, it must be people with other disability, with TB, with cancer, with all sorts of other things, and these things can't be separated. Let's also be realistic. We need to stop the rhetoric. You know, I've been to the last few international AIDS conferences, which I'm sure some of you have been to, or maybe you've read some of the literature over there, and they're very, very medical. And there's this kind of euphoria at the last conference where people were talking about the end of AIDS. And if you come to KwaZulu-Natal, if you come to South Africa, I'm sure any of you listening in Africa, even parts of America, Europe, we're nowhere near that. And we need to be more realistic in our targets. It's wonderful to dream and to, you know, really strive for excellence. But as you saw, those 1990 targets, we far off, you know, and with that, you know, 90, a lot of people are now talking about this fourth 90. It's all very well getting people on treatment and virally suppressed, but we've got to look at a quality of life 90, and that's not just for HIV, for all sorts of conditions. We must work across disciplines. You know, I'm a physiotherapist, and many of you might be, but we've got to work with our colleagues from other rehab professions, also people working with other conditions, and that's what I like about this group. And see how, you know, rather than fighting with each other, working together for the best of the people who need it most. South-North collaborations, I've been political there, I suppose, and put the South first because, you know, a lot of the funding does come out of the North, and a lot of great research is done from the North, but there needs to be more of a understanding of the great work that's being done in the South, and I'm talking really of resource poor, low-income countries across the world, and great researchers who don't have the funding, who might not have the name or the publications, but I think really we need to listen to these people and ensure that the collaborations are genuine, authentic, and, you know, relying on the best that everyone can bring to ensure we really get somewhere. You know, we talk about Rehab 2030, and I saw some great work being done there at the WHO, you know, the call for action, that document that's out, the Sustainable Development Goals. But we're not going to get there if we don't really work on some of the things I've talked about here. But there are many, many things I haven't mentioned perhaps, or I'm not even thinking about. And, you know, I've put there what else, and that's, I'd love to hear your guys' input, not just now, but beyond, you know, in terms of contacting me on email. I can link you to people doing great work across this continent. So, in conclusion, it's quite apt. I did these slides a few days ago, and, you know, a lot of people, when they think about South Africa, they think about Nelson Mandela. And Mandela was a wonderful man, and one of his, by his own admission, one of his blind spots was HIV, you know. He was doing an amazing amount of work in freeing our country and making it the democracy it is today. But, you know, he took his eye off the ball a bit, not just him, but a lot of leaders at the time. But he turned it around, and towards the end of his days, he was a great advocate. And that's a picture. It's a bit blurred, but you can see him wearing his HIV-positive T-shirt. And as it turns out, today is Mandela Day, the 18th of July, which is celebrated in South Africa. And he would have been 101 today. So in the spirit of Madiba, you know, I'm so proud and happy, and, you know, I feel honored to have been able to present this. So 2 points of conclusion is, you know, home-based rehabilitation really can confer a number of potential benefits, not just for people living with HIV, but people living with disability and all sorts of other conditions. But clearly, we need more research, and probably more importantly, more advocacy to ensure that, you know, rehabilitation for all is not just pie in the sky, but it's something that really becomes a possibility for those people who need it most. And like I've shown, the burden of the disease is here. It's in sub-Saharan Africa, in other poor countries. And the focus of the research and funding and efforts really needs to reflect that, I think. Not just the odd speaker at a conference, you know, but a real focus on giving African researchers their voice. A nice quote here I'll finish with. It says, HIV is a virus, stigma isn't. One has a cure already, and we know, sadly, stigma doesn't. But, you know, rehabilitation is one of the things that can help address stigma and all the challenges people with HIV face. I've got some references. This is a nice online reference that I was lucky enough to be involved with developing, and it was developed by the amazing people at QIGA, which was QIGA, Canadian Working Group for HIV and Rehab, is now called Realize, and they have a wonderful resource, and they wanted to adapt it for sub-Saharan Africa and make it a e-module, and that's what this is. So if you go to that web address, you'll see all sorts of information. Yeah, so particularly for my colleagues in Africa, this is a great resource, but I think it's useful for anyone across the world. And those are my references. I'm not being overly proud here, but you know, the topic reflects my PhD, so I've put the papers from my PhD, as well as my colleague Garita Chetty's theoretical paper, and then the 2 papers from my PhD supervisors. So I'm happy to share lots and lots more references in this area, but these are the kind of references that reflect the work done in my discipline in South Africa. That's it, everyone. Thank you very much for listening.
Bravo, Saul. This is very impressive. I really admire your work. I'm going to open up people's microphones right now, so if anyone has a question they want to ask you through audio or through the chat line. So if does anyone have any? Yes.
Hi, Saul.
Hello, Nina.
Yeah. Thank you. Yeah, this was quite an erudite presentation, and I can relate so much with it coming from Nigeria.
Yes.
Yeah. Yeah. So we have this patient, we tell them rehabilitation can help, but most times they can't get to the clinic. So I have been looking at how to take rehabilitation to the community. And I'm excited we have explored that in a wider way. I have done a case study, and it was beneficial, but I've not been able to do it with many patients. So
yes.
when I came across your work, yeah, like, yeah, this is it. I want to encourage this is really something to explore in a resource limited environment. Yes. And like you said, we have to be real. The reality is that HIV is still with us. And
yes.
there are lots of people that are affected by HIV, apart from those that are infected. I did a study last year, and I wasn't happy with some of the new cases. I wanted new cases, but they came so easily. It wasn't a good thing at all. People are still getting infected. So I want to thank you for what they do.
Thank you, Nina, and I'd love to hear more about your research. You know, feel free to drop me an email and keep up the good work. Yeah.
Thank you.
I think John has raised his hand. I don't know what to do, Jackie. If you were in my class, I would say, please speak, John.
John, you can speak.
Or type a message if it's easier.
Yes, if you want to type a message. Oh, hello.
Hello.
Now we can. Hello.
Hello.
Yes, we can hear.
John.
Hello.
We can hear you. Hi, John. Hi, John.
Hello. Hello.
Yes, we can hear you, John. Ask a question.
I thank you for this.
Thank you.
Just commend you for the effort to put in, and I have grabbed
John, you're breaking up. I wonder if you can perhaps type a message for me.
Just like study but I get a liability member that are appointed by people through can be
Sorry, John, I can't hear at all. I'm hearing just snatches of conversation. So if you could type your question.
John, Jackie, I think we're going to get back because there's 3 phones that you have, and we can't hear you. So if you turn 2 of your phones off, and then that or type the message. In the chat line, if you go to the top, the menu, you can type your question. I'm sorry, sometimes things don't work, internationally.
I did see a question from John that I hadn't answered, but I can just take the time to answer about adherence or completion rate. So we measured adherence through a daily diary. We gave each participant diaries and taught them how to fill it in, so we could look at how often they did the home program, and then obviously we knew how often we were going to see them. 4 out of the 38 did not complete the 16 weeks for different reasons, but we did an intention to treat analysis. So, it's the most robust method. We actually included them in the analysis even though they dropped out. So it's arguable that the results would have been even stronger if we had only included 4 who completed the program. But I think you have to look at reasons why people would drop out. But we were quite happy with that completion rate of 34 out of 38.
Saul, if you could go back to the first slide and people can write down your email address.
Yes, of course.
If they have questions after the session, which I'm sure they will, or some of the people that watch the recording will have. And so what we'll do is we'll place a recording of this presentation on our WCPT IPT-HOPE subgroup website so people can watch it who were not able to attend, and then they'll have the ability to contact you with further questions. And before signing off, I just wanted, of course, I wanted to thank you again for an excellent presentation. Like I said before, I have so much admiration for you and your work. Nina Chegbo, who's our education director, our education lead, will be sending you an award for your presentation. It's an International Scholar Award from the IPT-HOPE subgroup, and we hope you will accept with all the honors that you deserve. So,
thank you very much.
Oh, you're very welcome. It's such important work, and we hope we can help assist you with supporting getting the information out and sharing your information around the world. There's several comments on the chat line thanking you for the presentation.
Thank you. Thank you very much. And yeah, I'm just having a quick read through them. I don't know if we have time, but John's written, I was just making a contribution that implementation research is needed to solve the issue of coverage. I absolutely agree with that. And this is where we really have to make our research count, you know. It's no good me going and helping a small number of people for 4 months. Well, it makes a difference to those people, those 38 people, but it's a drop in the ocean. So we really have to get it into policy. And CBR is very, very poorly implemented in South Africa. I don't know about the rest of Africa, but one of my PhD students is actually looking into exactly this, is how we can better implement CBR in this province, KwaZulu-Natal, which will go some way towards addressing some of the issues I've spoken about today.
Well, thank you so much. So if there are no final comments or questions, I'll give people a minute to ask a question or type something in. Otherwise,
I think there was one here about how did I think from Amelie, I'm not sure, but how did I come up with a follow-up? How did you come with follow-up to your patients in the community setting, considering the number? And I presume that means people we saw, you know, post the intervention. And it's difficult, it really is, because people move around, you know, they move around in the community. They either don't have a cell phone or mobile phone, or they're using a phone of a family member. So, you know, people might be unemployed, but when you get to their home in the middle of the week, they've managed to get some part-time work. So obviously work becomes more important than rehab. So it was difficult. This was real-life research, and that's why we have to be realistic when we talk about how many people we can actually see in any given day. And then the follow-up in terms of following up a year later was we looked at qualitative research, so we were essentially looking for saturation in our data. And so we ended up interviewing 8 of the 34 participants who finished the intervention. But that, if you want to look at the references, you'll find all that information in the papers. And if anyone's struggling to get any of those papers, most of them are open access, but if you can't get any of them, I'm very happy to send the PDFs of those papers.
Okay. Can I ask a question?
Yes.
Can I ask a question?
yes, you can ask a question.
Okay. I was thinking of something. Is it possible, this work is a very good one, I appreciate it. But I just thought about it just now. How would a home-based rehabilitation sound when you get to gather much more people together, or probably have them do some of these interventions amongst themselves? Since Saul mentioned that having to see quite a small number of people at a given time is just like a drop in the ocean. So I just thought about it. Could it be? Could much work be done, or a work be done where such intervention is made in a group form? I don't know.
Yes, I heard that. So the question is around delivering these sorts of interventions in a group form, and that's a wonderful question, and it's indeed what actually ended up happening in practice to some extent. I think particularly with people who aren't living with severe disability, that's a possibility. There are some challenges. People live in very difficult terrain, quite far from each other, and what I didn't mention is because stigma is such a problem, a lot of people haven't actually disclosed their HIV status. So even in my study, effectively, of course, the participants knew they were HIV positive, and I did, but to all intents and purposes, I was coming and delivering an exercise intervention in the community. But I think that's certainly how things should go, where, as I said, we move away from HIV exceptionalism and go into communities and find anyone who's struggling with any sort of activity or participation restrictions for whatever reason, and look at getting community groups together, much like they have adherence groups and counseling groups, is actually looking at exercise groups, because there's no ways we could possibly treat everyone individually. You know, the severe cases of disability, I think it's still important that qualified rehab professionals are getting to those people's homes and treating them in their own home to spare them those barriers I spoke about. But for other people, certainly, I think group exercise interventions are crucial, and these are the kind of novel interventions. People are doing them, but we need to see them being written up and shown to work. Thank you for that question.
Yes, this is Jackie again. That's an amazing idea, to treat the disability and not, you know, be aware of what's going on with the disease, but not be focused on the disease, because that helps, you know, preserve people's privacy and confidentiality, and aims to help them get better. So what a great
100%.
idea.
Yeah.
Yeah, I've learned so much from your presentation. I'm so happy that you presented, and great questions to everyone who attended.
Thank you, guys. Yeah.
Yeah. Anything else? I don't want to turn this off before everybody gets their questions answered. And Saul, you've been such a great speaker, and you know, a very generous speaker with your time. So.
Thanks a lot, Jackie. Thanks for helping to set this up, and thanks to everyone for listening, and those people who listen in the future, just for giving me this opportunity. I look forward to communicating with many of you in the future, and have a good morning or afternoon or evening wherever you are. It's dark outside now in Durban, because our sun goes down early in winter.
Well, thank you again, Saul, and I'm sure we'll be tapping you to come and present again as you continue your work, because it's so you know, overwhelming in terms of how many people you have to see with the sobering statistics, but it's so vital and important to these, you know, people in your community, and then for the rest of us to hear and learn from it. So thank you once again.
Sure, it's a pleasure. And just a last word from me, as happy as I would be very happy to do more of these kinds of sessions, but there's a number of other wonderful researchers, you know, I can recommend and link you to, including some of the people I've mentioned in this presentation.
Okay, that would be great. All right, thank you again so much, Saul. And I'll say...
All the best, guys.
Yeah.
Have a nice evening.
All right, thanks.
We say Hamba Gasle in KwaZulu-Natal, which means go well.
Thank you very much. So,
all the best, guys.
Bye. Bye, Jackie.
Bye.
Bye.
Good night. Good night.
Bye, Frank.
All right. Good night, Emily.